Hello, everyone. Thank you so much for joining us for our webinar, Personal Recovery in Bipolar Disorder. I'm honored to be joined and to introduce our two presenters today, Dr. Barbara Mezes and Professor Steve Jones. In the first 45 minutes of this webinar will be their presentation, and then in the last 15 minutes, we'll have a Q&A where you can ask any questions in the chat or Q&A function. Thank you both for joining us.
Thank you.
Thank you. Good morning, everybody, and thank you for joining us and a very warm welcome from us. My name is Barbara Mezes, and I'm a senior research fellow at the Center of Resilience for Social Justice. But before my current role, I completed my PhD at the Spectrum Center for Mental Health Research. And today we will discuss this project and some other projects that we conducted at the Spectrum Center focusing on personal recovery. The Spectrum Center conducts translational research into the understanding and the psychology of bipolar disorder and other related conditions. And the team actively collaborates with people with lived experience of bipolar disorder, their family, and people who are in general interested in mental health research. And translational research means that we are using the research findings to inform clinical practice, so to improve psychological interventions and treatments available. And I will be co-delivering this session with Professor Stephen Jones, who is one of the co-directors of the Spectrum Center.
Hi, everyone.
Would you like to...
Yeah. Thank you, Barbara. Yeah, just pleased to meet everyone and glad to have this opportunity. And yes, just for information, I guess the Spectrum Center has been well summarized by Barbara. We've been around since about 2008 doing a range of work, and yeah, be good to just get the opportunity to share some of that with you. Okay, thanks, Barbara.
Thank you. And so first, we would like to give you an overview of what we will cover today in this webinar. We will start by introducing the concept of personal recovery and explaining why it's important. And then we will specifically focus on bipolar disorder, and we will discuss what personal recovery means for people with bipolar disorder and how this conceptualization differ from definitions of clinical recovery. We will then talk you through the current state of literature and research in this field, specifically focusing on how recovery has been defined by and measured for individuals with bipolar disorder. Following this, we will present a research project, which was part of my PhD work, where we explored whether psychological factors or different ways of thinking may support or hinder recovery in bipolar disorder. And then we will close this webinar by introducing some really promising therapeutic approaches to facilitating personal recovery in bipolar disorder. So firstly, the term recovery, what does it mean? So it has two key meanings. The first one is clinical recovery, which is usually defined as symptom reduction and relapse prevention. And these are still important aspects of recovery, but service users have emphasized other things in their recovery experiences. For example, empowerment, living a fulfilling and meaningful life, socializing and functioning successfully both in their personal and in their professional lives. And this is known as personal recovery. And the idea of focusing on these additional aspects of recovery has emerged from the recovery movement, which began in the 1980s. And this individual process is often described with the journey metaphor. And so now we will show you a video which was produced by the Spectrum Center. And in this video, you will hear Rita, who has lived experience of bipolar disorder, reflecting on her personal recovery journey.
Recovery means to me getting up in the morning. It's about getting up and getting on with my life in the way I want to do it, not because somebody else says I can or I should or I shouldn't. It's about what I want to do with my life. I was told when I first got a diagnosis of bipolar disorder that I'd never work in a stimulating job again, and I was absolutely devastated because I believed it. For me, what I wanted to do is had a job, not just any job, a job that actually challenged me and made me think, and sometimes made me a little bit anxious or what have you, but within a controlled way. And I wanted to study because I didn't study at school, and I've been able to get on a master's course and do that. First of all, realising that what I was told by services wasn't necessarily true, and starting to question that. I was lucky enough to start working with some sort of psychologists who had a slightly different take on what you can and can't do in the road to how you do that. So from listening and being around that environment, I accessed some psychological therapy, and that was the turning point. The very basics. It was the first time ever I'd sat with somebody within services, or actually within my core group and family, since diagnosis, that somebody asked me what was important to me and what I wanted. All the other things was like, you're here because you're this, you're here because you need this, and this is what we're going to do for you. Not, there's a range of options and a range of choices. So he brought me into the equation of what we wanted to do, which was unusual in my experience. My experiences with services is they told me what I could and couldn't do. So it wasn't a negotiation. So what I wanted didn't come into the picture at all. And that's not an exaggeration. Until I actually sat in front of a psychologist and he said, he didn't bring in the diagnosis of bipolar. He didn't even, that session at all. It was about what that environment was about and what I wanted to get out of it in terms of how I wanted to move on. And it was really empowering. At first, it was about actually taking back sort of power in what I wanted to do. It was really that initially it wasn't about leaning towards a job or education. It was about putting me in the picture and me sort of like taking a step back and saying, actually, I can decide what's important to me. Let's actually start reminding you that actually you can decide what you want, and you are able to do that, and you can do that. There's a journey you might have to go on and things you put in place, but you can. But when you get to a stage there of when you actually start planning goals, at looking at how you can do that and what are the challenges, because I had a pattern of getting reasonably good jobs, lasting 6 months a year, maybe 18 months, and losing them for whatever reason. And it was looking a little bit around, it wasn't just about getting the job, it was about what was going on for me to get myself in a position for whatever reason to be unemployed again. So, and it was putting little things in place, like perhaps looking at a little bit about the overexcitement, about the overworking right at the beginning, and pacing myself and doing things in a different way. In my experience, there's a culture when you get a diagnosis like bipolar disorder, that there's a thing about the people around you, your family, your friends, services. It's about keeping you safe, to that over supervision of what you're doing. My family, my friends and services literally were trying to get me to steer away from what the therapist was doing, and that was really, it was really difficult for me, not just in terms of having to fight, but do you believe this person then? Am I going to end up ill again if I follow this through? What would be really much better if it was one of my sons, to actually, have some kind of system where the therapist works with the family as well, to sort of like help them understand the process and what they're doing. Because in my experience, as for me, and also running a support group, most people don't know what therapists do. They still don't, which is really sad. So, that's sad for the person, sad for the families. So it's not accessed as much as it could be. So in terms of recovery, when I first got a diagnosis, very first day, the psychiatrist said to me, you will never, ever be able to go on long haul flights or have a stimulating job again. And I believed it. I really believed it. And for me, that is like the upside down of recovery. It was about somebody already, just because of a diagnosis, limiting what I could do.
So as you could hear from Rita's experience, it's really important to focus on the personal experiences of individuals. And there are other reasons as well why it's key. And for example, it's important because many individuals with bipolar disorder never achieve complete clinical recovery. So there is evidence that the trajectories are different for clinical improvements and for personal recovery. For example, there are people who can achieve high levels of functioning while still experiencing severe mood episodes. And there are also people who experience very mild symptoms or none for extended periods, but still struggle with their everyday lives. And the importance of focusing on personally meaningful recovery outcomes have been encouraged by mental health policies internationally. But despite this, therapies and research had primarily focused on clinical outcomes. And this is problematic as it only shows a partial picture when it comes to test the effectiveness of different interventions aiming to support recovery. And even when an intervention aimed to target personal recovery, a key challenge often occurs, which is to provide an evidence-based intervention as well as personalize the support to enable the people to direct and have control over their own care. And Steve will talk more about this challenge and how some promising therapeutic approaches targeting personal recovery have overcome this challenge. In terms of the meaning of recovery, research has extensively focused on this topic, especially in severe mental health problems in general. So exploring how individuals define and talk about their recovery experiences. And Limi and colleagues brought together the learning from these studies and identified key themes from the narratives of people with mental health problems. And the identified conceptual framework is called CHIME. And according to this framework, the personal recovery involves the following key components, which are shown on this slide. So there is connectedness, where people emphasize the importance of support from others, for example, peer support, attending support groups, being part of a community, building and maintaining relationships. Hope and optimism about future was another key theme that people talked about. So it's the importance of believing that recovery is possible, having motivation, having dreams, future aspirations, and positive thinking. Rebuilding a positive identity or sense of identity, overcoming stigma, improving self-esteem, realizing achievements were also highlighted, as well as having meaning and purpose in life, for example, being in employment and or having meaningful social roles. Empowerment, including focusing on strengths, having control and responsibility over life, was another important domain of personal recovery. And this CHIME model was predominantly endorsed by other researchers, but they also highlighted some key challenges. For example, that it didn't focus on the characteristics of individuals, especially highlighting the lack of research focusing on mood disorders, and also that it mainly focused on positives and strengths and overlooked the themes around the challenges that the recovery journey may include. And so in response to this, our team embarked on completing 2 reviews on personal recovery literature with special focus on bipolar disorder. And one focused on qualitative information, for example, how people with bipolar disorder describe their recovery journey. And one on quantitative information, for example, how recovery outcomes have been measured for people with bipolar disorder. And in the first review, Jagfeld and colleagues identified that the CHIME framework in general was useful for understanding personal recovery in bipolar disorder, but recommended the poetic conceptual framework, which basically extends the CHIME framework with the tension domain that is specific for bipolar disorder. And this tension domain included themes such as balancing acceptance of limitations with ambitions. This means, for example, balancing the need to reduce work hours to support self-management with dreams and career aspirations. Or themes around being open about the diagnosis of bipolar disorder, which may facilitate support, but it may also enable stigmatization. Or people talked about their ambivalent feelings around hypomania, so highlighting both the positives and the negative aspects of it. Positives such as increased creativity or productivity, but also the downside of elevated mood, which may become uncontrollable. And in the second review, we explored how researchers have measured recovery, considering aspects of recovery which are beyond clinical recovery domains, so beyond clinical improvement. And we found that there was a lack of consistency in definitions and measurements used. So earlier literature predominantly defined recovery as reaching pre-illness occupational residential status. This was followed by literature considering domains such as social functioning. But even in this area of research, definitions were often circular. For example, not being clear about whether being in employment was a recovery outcome or it was an underpinning factor predicting recovery. And more recent research attempted to measure personal recovery in line with the personal recovery definitions, and also considered how ways in which individuals think and their circumstances, such as life events, may influence their recovery. And for some of these psychosocial factors, for example, resilience, are influential in recovery. However, this line of research is still in its infancy. But despite the limitations of the literature, a key finding of this review was that the different demographic, clinical, and psychosocial factors were linked to the different recovery domains in a different way. So there were some overlaps, but there were differences as well, which means that while there might be some similarity in these different domains in terms of what predicts the different recovery domains, but these domains are also seem to be distinct to some extent. And so we decided to explore psychological factors in personal recovery in bipolar disorder in more depth. Firstly, because this area of research is still in its infancy, as I mentioned before, but also because we know that although clinical and personal recovery are not the same, they are at least partially overlap, and sense-making processes seem to underpin both personal recovery and clinical recovery, which highlights the importance of psychological factors in these outcomes. And most importantly, identifying these different thinking styles of psychological factors can also provide information for psychological interventions so that we know what we can focus on, what to target. And the evidence base for psychological factors influencing clinical recovery is more established, and that indicated that certain psychological factors are important in relation to risk of bipolar disorder, influence clinical outcomes, and the course of illness. So therefore, we were interested to see whether these particular thinking styles or psychological factors would also be influential in personal recovery. So what are these different thought and behavior patterns? So numerous psychological models in the last 40 years have aimed to explain the development and course of bipolar disorder, arguing that genetic factors alone cannot explain the varied manifestation and course of bipolar disorder, and that individual experiences and circumstances are likely to play an important role. And also how people process these different information relevant to their different experiences. So these we call psychological factors. And we reviewed the psychological models of bipolar disorder and the proposed psychological factors, but the models suggested that would be influential in the clinical course of bipolar disorder. And we focused on the most well-established evidence-based models, basically, to select the psychological factors in this study. And some of the models proposed that negative and positive life events can trigger certain psychological factors or thinking styles. And often researchers and psychologists use technical terms for these psychological factors. So we will briefly mention these, but also explain what they mean by these terms. And the first one is dysfunctional attitudes or extreme attitudes towards goals and achievements. So this is, for example, the need to strive for unrealistic goals, such as constantly feeling well, having complete control over feelings and life, being able to solve problems easily, and achieve highly to be appreciated by others. And failure in these goals has been linked to self-criticism, hopelessness, and depression. But these attitudes may also lead to overworking, which in turn may introduce irregularities in routine, for example, reduced sleep, and can lead to elevated mood and hypomanic or manic episodes. Therefore, these attitudes may be linked to more severe course of bipolar disorder. Another psychological factor that has been linked to bipolar disorder is self-dispositional or self-referential thinking style. And this refers to thought patterns where individuals interpret changes in their mood as a personal characteristics rather than circumstantial factors. For example, interpreting racing thoughts as being full of good ideas rather than experiencing too much demands on time, or interpreting the feeling of being cut off from others as being an insensitive person rather than acknowledging that things are difficult at times and the person may lack energy for other things. But similarly, these thinking styles are triggered or can be triggered by life events and may worsen depression or mania by leading to spiraling negative or positive self-referential thinking styles. And certain coping strategies and how individuals respond to depressive mood have also been proposed to impact on the development and course of bipolar disorder. For example, rumination, which means directing one's attention towards one's negative emotional state, may contribute to depressive symptoms and episodes. On the other hand, risk-taking, for example, engagement in dangerous activities or excessive alcohol consumption and extreme distraction, which is a form of active coping, as a response to depressed mood may trigger elevated mood. And furthermore, there were other factors that have been found to be elevated in bipolar disorder and have been linked to predominantly hypomanic or manic episodes. And these included increased sensitivity to rewards. So we are all motivated by rewards or pleasant things in our environment. But for some of us, this sensitivity and motivation towards pleasant things may be even higher. Or higher levels of fun-seeking, which refers to motivation to find new rewards spontaneously, or higher levels of drive, which refers to the motivation to follow one's goal. And impulsivity, which is the tendency to act without thinking, and that has been proposed as a key feature of bipolar disorder and linked to more severe course and outcomes. So in this study, we asked participants to complete a questionnaire that measures each of these different thinking and behavioral styles, as well as a questionnaire that measured their personal recovery experiences. We had 107 participants with verified diagnosis of bipolar disorder who took part in this study. Their average age was 46, ranging between 23 and 77. They were predominantly females, approximately 2/3 of them, and were educated to at least at undergraduate degree level. 3/4 of the participants were in some form of education or employment. And on average, participants reported over 20 years since their first episodes, and approximately half of them had more than 20 episodes during this period. So this number of lifetime hypomanic and depressive episodes formed our clinical recovery outcome, because we thought about clinical recovery as a long-term cumulative clinical outcome. So the number of times when clinical recovery has been achieved after an acute episode. First, we compared the different demographic and clinical characteristics underpinning personal and clinical recovery. And we found that participants who were female and those who were married reported better personal recovery than compared to males and single participants. With regards to clinical recovery, only the education level was found to be an influential demographic characteristics. So those with higher education reported more manic episodes, which meant in this study worse clinical recovery outcome. Not surprisingly, clinical factors such as symptoms were more influential in clinical recovery. For example, experiencing recent symptoms or longer time since first bipolar episodes were all linked to higher number of lifetime episodes, and so worse clinical recovery in this study. Depressive symptoms were also influential in personal recovery. So those who experienced higher rates of depressive symptoms reported worse personal recovery. Most of these factors we cannot change or target in interventions. However, this is not the case for psychological factors, which I will talk about next. So what we found in terms of psychological underpinnings of personal recovery, we found that some of these psychological factors were influential in both personal and clinical recovery. For example, dysfunctional attitudes related to goal attainment and achievements was associated with worse personal and clinical recovery outcomes. Similarly, those who interpreted depression relevant experiences as personal characteristics rather than external circumstantial factors reported worse clinical and personal recovery. Those who were more impulsive reported more manic episodes and saw worse clinical recovery, but this was not the case for personal recovery. We also found that those who responded with active coping to low mood reported better personal recovery. And the supportive role of active coping in personal recovery is consistent with the literature, more specifically with staging models of recovery in mental health problems, where the final stage includes factors such as actively managing mental health problems. However, in our study, we found that higher rates of active coping was also associated with higher numbers of hypomanic episodes, which means was linked to worse clinical recovery experiences. And these results were found by other researchers in the past who explained it as with a potential explanation as distraction, a form of active coping, as a response to depressive mode to avoid depressive episodes may lead to overstimulation and disruption in one's daily routine, which could lead to hypomanic episodes. And this is called the depression avoidance hypothesis proposed by Thomas and Benter. Interestingly, participants who reported higher rates of risk-taking or more risk-taking behavior also reported better personal recovery. An explanation may be that low level of risk-taking activities can be a positive experience and linked to better personal recovery by maybe experimenting more, socializing more, or initiating more new relationships. And also unexpectedly, we found that those with higher fun-seeking, reward responsiveness, and drive reported less manic episodes and saw better clinical recovery. And this is in contrast with usual findings in the literature linking these factors to mania. So it's possible that post-manic episodes or antipsychotic medication may reduce the levels of fun-seeking, drive, and reward responsiveness, but this needs further exploration. The limitation in this study was that we only measured psychological factors at one time point. Therefore, we are currently exploring whether changes in psychological factors influence personal recovery over time. So what does this all mean for psychological interventions? Well, psychological interventions may support personal recovery by being flexible and holistic and targeting the needs of the individuals and not solely focusing on clinical improvements. An important aspect of these interventions may be enabling people to set and work towards realistic and achievable goals, whilst also monitoring life events and attitudes associated with goal attainment. Therapies could also enhance both problem-focused coping skills and such as actively challenging negative thoughts and resolving problems one by one, and emotional focused coping strategies such as balanced and monitored distraction and risk-taking engagement in pleasurable activities. And it's also important to help individuals to normalize mood experiences as opposed to self-blame or pathologize such experiences. And some of these strategies are already incorporated in different psychological interventions, such as problem-focused coping skills are often involved. But flexibility and targeting the interventions to the needs of people is really important. And next, Steve will introduce some promising approaches to do this in therapy.
Great. Okay. Thanks, Barbara. So, Barbara, are you all right to sort of keep charge of the slides and advancing this? Thanks very much. Great. Yeah. So Barbara's given a great sort of overview of sort of psychological processes in general and personal recovery. And for this sort of second half, we wanted to share with you some of the work we've done over the last few years, more focused around addressing personal recovery in a therapeutic way around bipolar. In terms of the focus for this work, we started off focusing on people with recent onset bipolar. And really that was because firstly, there's some evidence to suggest that psychological approaches may have more benefit when offered earlier. And also that outcomes long-term can also be worse for people with onset in early adulthood. So targeting younger adults with more recent onset seemed a sensible thing to do. So I think the wider literature says that delayed treatment can be associated with worse outcomes, and that's both in terms of sort of the functional side of things and symptoms. And also that possibly later episodes may end up being linked to events that had happened linked to previous mood changes, so they may potentially be triggered slightly more easily. And the sort of cognitive processes, the thinking processes that Barbara was talking about may be less easily accessed in relation to those. There's also evidence from sort of broader cognitive therapy studies in bipolar that potentially stronger effects are evident for people with fewer numbers of episodes. So those were some of the reasons why we looked at RFT, recovery focused therapy, with this group initially. Okay, thanks, Barbara. Yeah, so in terms of the recovery focused approach, and bearing in mind some of the definitions of recovery that Barbara's already provided us with, the intention was to provide an approach which is flexible and collaborative, with a focus on supporting the client to achieve goals that they personally value in therapy, and to essentially use evidence-based approaches from psychological research in service of those sort of goals. So the intervention was intended to be a structured intervention, but that was flexible and could respond to differing people's needs, that drew on the current evidence base around psychological research, but matches the intervention to the particular priorities of the client. As we've talked about before, targeting people early, in this case in their bipolar course, to help improve, hopefully, the trajectory of their experiences over time. And also picking up this issue of what we measure in relation to these things, actually trying to measure personal recovery as an outcome to see if actually our work is helping with that. Okay, thank you. So we've done work in different forms on this area for quite some years. So back in 2008, we did some pilot work with a series of people with early bipolar disorder to see what sort of things might be most helpful and what sort of things were valued by people. And that suggested the value of these sort of areas for enhancing outcomes for people who are in the earlier stages of their bipolar experiences. So flexible engagement was important, and that links to a number of people having a kind of ambivalent relationship with their experiences, particularly earlier on. So seeing that a degree of ambivalence around, you know, is this the right thing for me, being an entirely appropriate sort of response potentially to the early stages of therapy, and accommodating that in how we work with people around, you know, what they want and how to deliver it. A lot of people at that stage are still working out what diagnosis means to them, and being flexible again about what that meaning is for people, and not being rigid about people accepting a particular view of bipolar as a way into the therapy. So people coming with different perspectives and that being fine. Looking at what people can really do well as what things are challenging. So looking at coping skills and sort of more positive outcomes was important. And looking, and this relates back to Barbara's presentation, around how people think about their mood experiences and what the effects of thinking about those in different ways are. Okay, thank you. So the next stage of the work was to actually develop a manual that could guide a randomized controlled trial for us to begin to look in a bit more detail at how acceptable and potentially how effective this sort of work was. So in developing, given that we were looking at an approach which is all about what people with lived experience value, we thought it was crucial to develop that very much alongside people with lived experience. So there were lots of ways in which people impacted on this research. But some key ones were qualitative interviews with people to learn what people with bipolar experiences define for themselves as what counts as recovery in terms of personal recovery. And also we had a series of focus groups with people with lived experience to understand more about what people might want in this sort of intervention, in terms of what would they want in it, in terms of content, what sorts of formats might be helpful, and also what kind of supporting materials might be the sorts of things that people might feel was kind of positive and engaging around this sort of topic. Okay, thank you. Sorry, what's this slide, Barbara?
Sorry,
oh,
you
right.
want me to move on or go back?
No, it's the one, I think there was one about the qualitative work. Is that coming after that one? Because on my version it comes earlier.
This one?
Yeah. Yep. Okay.
Yeah, sorry, I don't know why the order may have changed. I don't know how.
Okay, so talking about the qualitative work that we did, these are the sort of key aspects of personal recovery that people talked about who had early bipolar disorder, and that really influenced both the intervention and how we measured personal recovery. So people very much wanted to have, it was important in terms of their sense of recovery that mood experiences were seen as understandable and manageable. And the key thing there was that the model that the individual had made sense to them. So the models people had were quite varied. So it was the sort of personal sense that gave them purchase and understanding that was key in that sense of recovery. Another aspect was developing resources to self-manage health, and that was around, it wasn't about managing everything yourself, but about having a sense of sort of autonomy and control, so that, you know, when things were difficult, you know, being able to call on people in both in clinical settings or informally for extra support and help, but also when things were going better, for the system to have enough flexibility that people, you know, adopted more control and were sort of more actively managing the resources that they found helpful to keep or enable them to live well. Access to personally meaningful activity is around, again, being able to engage in work or other activities which are valuable to that person. And those, for some people, were about going back to things that had proved difficult during a sort of significant mood episode. But for other people, it was thinking about the experiences they'd had and, in a sense, what they'd learned from those and what new things they wanted to do going forward, which might actually be really rather different from what they'd done in the past. And then Barbara was mentioning the journey metaphor earlier, and people did very much identify the importance of seeing recovery as kind of a lifelong process with twists and turns and ups and downs, but the key thing being seen as being in that process rather than that recovery is like an end point that until you've reached it, that you're not sort of engaging with it. Okay, next one, please.
Is this the right one, or shall I jump?
That's fab, thank you. Yeah, so and then, as I said, we did focus groups with people, and these were some of the things that they highlighted that really want to see in a recovery focused intervention. So they said that a lot of their sort of experiences in sort of engaging with clinical systems was about what was going wrong, what was wrong with them, what needed to change. And whilst they could see that that could have it, you know, there were some sort of merits to that, they also wanted some support around understanding kind of aspects of hope and opportunity, because they felt that that would really help them engage with the wider work. Being flexible about the timing and location of the intervention, again, like the case series came up, because different people felt they'd be more comfortable engaging in different places, for instance, and different people found it more or less easy to engage in the morning or the afternoon, and so on. People wanted good quality supporting materials, so they wanted a range of things alongside the intervention, including stories of recovery from other people, so that they could read those and sort of get a sense of the different ways people had addressed this in the sort of wider world. Also having a way to record learning from the work they'd done, so a recovery plan that they could take forward after the therapy had finished. And people wanted the option to share this with others, including, for instance, their mental health team, but they wanted to do that based on their own control. So they didn't want that to be like a default that just happened. They wanted to be able to decide whether that happened or not. And they also wanted the intervention to measure functional outcomes, so how people were getting on with their lives rather than just what sort of symptoms they might be experiencing. Thank you. Great. Okay, so recovery-focused therapy differs from the earlier forms of cognitive therapy for bipolar that are in a range of manuals in a number of ways. So there's a very explicit focus on the client's own goals and eliciting those, rather than assuming that relapse prevention and mood stabilization are the key and essentially only targets. So those aren't ruled out by any means, but they're not assumed to be the focus. And in practice, when people have engaged with this intervention, they've had sort of very varied routes through it. Having a personalized formulation to understanding people's experiences, rather than having a kind of particular model that suggests that people have particular coping styles that lead to worsening of particular outcomes as being the only thing to highlight. Being flexible about the model that the client brings and working with that. And also being really open to working with the other things that people might bring. So difficulties with sort of social relationships or day-to-day sort of functioning, and also other things that, you know, lots of people with bipolar, mood is one issue, but anxiety could be another issue, or substance use could be something. There's a range of other challenges people might be living with. So being sort of open to working alongside those as well. Okay. Thank you. And in addition to the formal therapy sessions, in response to the focus group suggestions, we created with people with lived experience a tools and choices manual. And the idea of that was it allowed people to have like a repository to record their own notes in relation to sessions, to benefit from information from other people, including the recovery stories that people mentioned, as well as information about their sort of own learning from their work with the therapist. So as you can see, there's sort of administrative information in section 1. In section 2, there's information about other resources, but also service user poetry, because that was something that people felt would be helpful. There's a whole section on recovery stories from other people, and then people collecting their own information. So information about the pattern of their experiences and their moods and their day-to-day functioning, and then tools around addressing particular issues. So whether that's sleep or coping skills or day-to-day functioning, and keeping to a recovery plan, and also future thoughts and ideas. So the idea of the intervention was to give people these tools. And so the intention, or the focus, wasn't on fixing people in inverted commas, but giving people things that would potentially be helpful for them to use, obviously in therapy, yes, but also to use subsequent to therapy to kind of carry on with the process of building their lives in the ways that they wanted to live them. So we did a randomized controlled trial, which was intended to look at whether recovery-focused therapy helped with personal recovery. And also because for prior research on other interventions, the primary outcome tended to be relapse. We wanted to see how did this perform in relation to whether people experience more or less mood episodes with the intervention. So these were people with less than 5 years of bipolar and who met criteria for bipolar disorder by structured interview. Okay, so the primary outcomes were, we first of all wanted to see whether it was feasible and acceptable. So if we offered people the opportunity to be in a study of this type, would they come? Would they stay in the study? What would they think of it? And also we wanted to know about the intervention. If people were offered the option of the intervention, would they take it? And if they started the intervention, would they persist with it? And what sort of outcomes might we get? And then, as we've indicated, we were also measuring personal recovery, and we were measuring time to relapse using repeated structured interviews with people throughout the study. Okay, so in terms of feasibility, the therapy, the recovery-focused therapy, was offered to 33 people, and 32 of those attended at least 6 sessions. So the vast majority of people attended a decent chunk of therapy. And in fact, the mean number of sessions attended was 14 out of a maximum of 18, which is a very good ratio for a psychological intervention. We also had a couple of scales to look at therapists to see if therapists were actually delivering the intervention as intended. And the measures suggested that indeed they were, both in terms of evidence-based tools that people were being given and also maintaining the recovery focus. So what were the clinical outcomes then as well? Can we move to that? Thank you. So this graph, so the dark blue is people who've received the recovery-focused intervention, and the light blue is people in the treatment as usual arm. And this is their bipolar recovery questionnaire scores. So if you look at baseline, which is the start of the study, if anything, people in the recovery-focused intervention in dark blue had lower levels of personal recovery than people at baseline. But if you look at 6 months, which is the end of the intervention, and 12 months, which is an additional follow-up period, at both points, the personal recovery of people who've received the therapy is higher, and as well as being visually different, those differences were statistically significant. Okay, and looking also at time to relapse, so this graph shows the time to relapse of people in the treatment as usual arm in the bold line, and the dotted line is people who've received recovery-focused therapy. And if you look at the top left-hand corner of this, where both of the lines are together, that's the start of the study where everyone is out of episode. So that one represents 100% of people are not in episode. And if you look at the solid line, that drops to 0.5, which is 50% of people are not in episode and 50% are by 10 weeks into the study. In contrast, if you look at people who receive the intervention, the drop to 50% of people being out of episode doesn't happen until 60 weeks into the study. So it delays the onset of an episode, and there are fewer episodes in people who've received the intervention versus those who haven't. So that looks promising in terms of people seem to like it, and it suggested that there were benefits in terms of the intervention. We've also adapted this for older adults to see whether this is feasible and acceptable for them. So it's a similar sort of intervention, but a slightly shorter one, 14 sessions, which was informed by our data from the early bipolar intervention that people seem to that seemed to be the sort of optimum number. Okay, and in terms of the sorts of results we got there, so we had 39 people, mainly women, and the mean age was 67. In terms of whether people would engage with the study, the evidence was that there was quite a lot of enthusiasm for that. And actually, once people were in the study, they were great at sort of completing the measures. So more than 80% of people completed measures at the 2 time points of follow-up for the study. And in terms of the intervention, again, people were keen to have it and stuck with it once they'd started receiving it. So almost 70% of people attended all the sessions, and 90% attended 6 or more. And those people that we interviewed after the intervention were highlighted positive benefits from the intervention. And there were signals from the clinical measures we used that suggested there were improvements in relapse and mood symptoms and functioning for people. So just in conclusion, in relation to the sort of therapy side of things, it seems that this sort of approach is at least feasible. So people will engage with the studies and they'll engage with therapy. There are good signals for clinical outcomes in both in terms of recovery and in terms of clinical and functioning outcomes. And there are promising results for similar sorts of things with older adults. Okay, thanks very much. So Barbara, I'll leave it to you to sort of summarize.
Yes, thank you, Steve, and apologies for not being a very good job at controlling the slides. So just to summarize, we talked about the different psychological factors that underpin personal and clinical recovery and how they showed some similarities. For example, dysfunctional attitudes and self-referential thinking styles were important in both. But we also found some differences. For example, risk-taking and active coping were more important in personal recovery, whilst the impulsive and reward motivational behavior was more important or influential in clinical recovery. And these results have implications for psychological interventions aiming to target personal recovery. And we talked about recovery-focused interventions for people with early bipolar disorder that also shows promising results for older people with bipolar disorder. And next stage will be to conduct a definitive clinical trial to confirm the effectiveness of these promising approaches. So here we've added some of the key articles we talked about and some few further reading that you might find useful. And if you would like to find out more about anything that we covered today or identify further reading, please feel free to contact us and we can direct you to the right resources. And thank you for your attention. And if you would like to hear more about our work, please visit our website or follow us on social media. And if we've got time, we welcome any questions now. Thank you very much. We'll stop sharing the screen.
Thank you both so much for such a wonderful and insightful presentation. I think all your guys' research and information will be super helpful to folks along their own personal recovery journeys. So we have a couple questions from the audience. First, to start, we have a question from David, and he was wondering, how does comorbidity affect recovery or in your research? Specifically, David was wondering if you have any insight regarding personal recovery in borderline personality disorder and bipolar disorder.
Do you want me
Steve, would you? Yes, please.
So in terms of our work, we don't have a definitive answer to that, I'm afraid, at the moment. So we certainly obviously in terms of the sort of experiences that people have, as people would know, there are sort of subtle differences, but lots of overlap in the experiences that people have that are related to sort of being given a borderline personality diagnosis or their bipolar experiences being identified as a bipolar disorder as such. So there are people that have both of these in parallel for quite a long time. And there are also people who have one and then the other or oscillate in and out of those. But I think the principles of finding a way of living well with a range of experiences seem to work, across those in a sense, because we're not sort of slicing it in terms of what sort of mood experiences are you defining yourself as having. We're sort of slicing it more in terms of how do you want to live your life alongside the challenges you might notice. So there were certainly people who would have met borderline criteria in the studies, but we sort of, for the reasons I've just sort of described, we haven't particularly highlighted it. It's a really good question. And we're actively seeking further funding to do this at bigger scale with wider ranges of people, and that will obviously help us to drill down into the sort of data in that kind of way.
Yes, definitely. That's so insightful, and I think I hope, and that we'll continue our research into more dual diagnosis. Another question we had was from your mentioning of an implication of one of the psychological interventions is normalizing mood experiences. Do you have any tips on how you do normalize a dysfunctional mood?
Barbara, do you want to do that? Or do you want me?
Yeah, I can try and then you can chip in if you would like. Yeah, so during my PhD, I was conducted some interviews with people with bipolar disorder, and this came up actually as a topic of great importance of how people, when they experience changes in their mood, immediately they think about that this is going to lead to an episode or it will escalate. And they highlighted the importance of everyone experiencing mood fluctuation, changes in mood. And sometimes you need to step back and think about it, that is it something that is likely to lead to something more serious, or is it something that would normally be experienced by anyone as a reaction to life experiences, events happening, or even just having a bad day, not immediately jumping to the conclusion that this might escalate into a mood episode. So that was one of the suggestions. They had to kind of step back and try to think about it in this way. But Steve may have something more to add about this.
That's really helpful. Yeah, I mean, I guess I'd say maybe a couple of things. One is that there's lots of evidence that sort of mood experiences and mood variation are very much like on a continuum across the general population. So when you look at sort of patterns of mood in people who have a diagnosis of bipolar and people who have up and down mood in the general population, those patterns are quite similar, although the sort of degree to which things vary is a bit different. But it does mean that one thing to think about is the things one does can influence whether you move up and down that continuum. So some of the things Barbara was saying are things that can help sort of move you away from the sort of the more mood episode side of that variation. And I guess the other thing is, I mean, Barbara looked at the way you think about what your mood means, and that can also be helpful. So if your mood in converse, rather than going down, is going up, there can be, if you're thinking about that as revealing your true self and being something that you need to amplify, obviously that's quite likely to lead to, the mood eventually getting somewhat out of control. Whereas if you're able to think of those mood experiences as mood experiences and in a sense get a sense of what in the environment might be actually sort of triggering that, then it can be easier to sort of think, okay, well, that's something, again, maybe I need to step back from that. Maybe I need to think of some sort of calming things to do or focus on something moderately less stimulating. And quite often those relatively sort of simple, in inverted commas, approaches, people talk about those as being relatively helpful.
Awesome. Thank you so much for that. I think it's super important to just always take a step back and reflect for a moment. Another question we had was wondering about if there are any well-known treatments specifically for impulsiveness, or whether RFT would be a solution for impulsiveness.
Yeah. I mean, so there's, outside bipolar, that there are interventions that, in a sense, are targeted specifically at impulsiveness. So some of the attention deficit disorder sort of interventions are very much around stopping and thinking and that sort of thing. But I think one of the things is that in terms of impulsiveness in bipolar, there seem to be lots of things that drive that. And so I think, RFT and to an extent sort of other forms of bipolar intervention can be useful about, having a sense of where things are coming from and why they're happening and what you can do about it. I think, does help dilute the sort of the impulsiveness, because I think we tend to sort of work with people around understanding things like impulsiveness as being much more of a, if you like, a personality tendency, like extroversion or loads of other things. It's not so much, it's not a fault, it just depends in a way how you use it. And so trying to think how to use it when it's helpful and use other things when it's less helpful can be sort of a way forward. That certainly would be something we would cover in that sort of intervention. Yeah.
And I also wanted to just add that I think, it also depends on what someone might bring to the therapeutic session. So because it's personalized, it allows you to reflect on your own experiences and challenges and kind of what you find difficult, and these kind of areas may appear, and then that can be one of the targets of the psychological support that is received.
Awesome. One of our second to last question is from Susan. She said, thank you so much for focusing on early intervention. Have you studied recovery focused therapy in college students, especially those who are isolated on a mental health leave after a bipolar diagnosis?
Yes, that's a really good question. We haven't specifically done that. We're just actually about to start a trial that's looking at help-seeking young people who haven't yet developed a bipolar disorder, to see if these sort of approaches similar to this can be helpful there. So people with kind of unstable moods, possibly some depression, but who don't meet bipolar criteria, to sit, and those will be a mixture of people. So, sort of, some of them will be students, but some of them will be people who are trying to get into employment or struggling to stay in employment because of what they're experiencing. So there's been some pilot work in that area that suggests that can help reduce the risk of developing full bipolar, which obviously is important. And the trial that's starting in April is a much larger one to get a really clear idea of exactly how well does that work. So there's not specifically been a student-focused study, but that will incorporate students in it.
Wonderful. Hopefully more research will be done and we can continue to answer great questions like that. Our last question, folks were wondering whether they would be able to access these slides and whether they would be available after the presentation.
That's fine with me, if it's fine with you, Barbara.
Yeah, absolutely.
Okay, awesome. If anyone would like to see these slides, you can email ibpf@mburgess@ibpf.org, and we'll be glad to share them with you to help you on your own personal recoveries. If there are no other questions, I think we'll wrap up our session. Thank you to everyone for joining us, especially our speakers, Dr. Mezes and Professor Jones. We're so grateful for you sharing your research to help folks in their recovery in bipolar disorder. If you enjoyed today's webinar, make sure to drop a like and subscribe to our YouTube channel below, as it helps us grow and continue to bring you guys more webinars. Thank you all again, and we look forward to seeing you at our next webinar.
Thanks, everyone.
Thank you very much. Bye.